until yeah, probably we won't do biostats.
Okay. A 2-year-old girl A 2-year-old girl is admitted to the hospital for treatment of the pneumococcal bacteremia. Over the past year, she has had 3 episodes of acute otitis media, 2 episodes of bacterial pneumonia, recurrent episodes of thrush, recurrent episodes of thrush. Her mother has a history of persistent oral candidiasis and chronic diarrhea and has had 9 kg weight loss over the past 3 months. The patient is at 50 percentile for height, 5 percentile for weight. The oral mucous membrane are covered with white plaques. Examination shows 2 centimeter non-tender axillary lymph node. The spleen is palpated 2 centimeter below the left costal margin, and the liver is palpated 3 centimeter below the right costal margin. Lab studies show leukocyte count 5,000, segmented neutrophil 65%, lymphocyte 35%, platelet count 95,000, IgA is high, IgG is high, uh, IgA high, IgG high, IgM high. Everything is high. What is the following mechanism is most likely cause of this patient's symptoms?
How old is he? 2 years old. I see the Whiskered Aldrich. Is it the Whiskered Aldrich? You say it was thrombocytopenia. Um, maybe.
You are thinking about Viscott Eldridge,
Yeah, last time you say it was thrombocytopenia, and then what
but
else?
Viscott Eldridge is B and T cell deficiency.
B and T cell. No, and it's not that.
If B and T cell deficiency, then these would be low, not high, isn't it?
Yeah, it will be low. That's true. If it's the anti cell. Lymphocyte, blah blah blah. It's not common variable. Is B cell, but
B cell,
B
yes.
cell is fine here. Shidia Kigachi is the oculocutaneous guy, but I don't remember what else he had or whatever.
It is phagocyte deficiency, not B and T cell.
Yeah,
This has one probability. Chronic granulomatous disease.
that's the catalase guy. So it
Yes,
will work. It will work for candida, but
Uh,
bacterial pneumonia is
but bacterial pneumonia can happen. Staph,
for
cat need places.
bacterial maybe
Pneu-
that you said
Pneumonia
it.
can happen.
For staff.
Yes,
Oh yeah. That's true.
isn't
That's
it?
true. Yeah, yeah. I mean, I thought pneumonia was mostly strep, but may I guess yeah, staff. I guess. Okay. It's not terminal complement. That's Neisseria.
Terminal complement. Oh, yes,
Yeah, and it's
terminal
not HIV.
complement is Neisseria.
Yeah, and it's not the HIV will be no. I think HIV lymphocytes will be the window. Okay, and let's go with the
CGD.
granular CGT. Wait, where am I? Nope, it's not this one. Oh my goodness. Uh, 26. Uh, okay, so it's no, it's definitely not CGD. It's HIV. Oh Lord, HIV. HIV infection. I feel like we had one question similar like this before. HIV infection acquired via vertical transmission in the perinatal period is most likely diagnosed with history of recurrent oral thrush, otitis media, bacterial pneumonia, as well as cervical lymphadenopathy and hepatosplenomegaly. on exam. HIV transmission may occur at any time during gestation, but most acquired at or around the time of delivery and in the immediate postpartum period when the newborn is breastfeeding. Transmission is uncommon if the mom is taking antiretroviral and has a low viral load. As a result, universal screening for HIV is most, yeah, okay. Although this, whatever. Most patients present within the first few months of birth with recurrent pneumonia, opportunistic infections, though in some cases, symptoms and AIDS defining conditions may not develop until many years later. Initial evaluation should include measurement of HIV viral load with concomitant testing for mutations. While this patient should receive treatment for her bacterial pneumonia and thrush, she should also be started on antiretroviral therapy and HIV once HIV is confirmed. It's not chronic, it's not Shigati-Dashi caused by mutation of the lysosomal trafficking regulator gene essential for normal transportation of the lysosome within the cell. Present with recurrent bacterial infections, oculocutaneous albinism, peripheral neuropathy, progressive neurological. It's not CGD caused by deficiency of NADPH oxidase, an enzyme used to generate hydrogen peroxide and hypochlorous acids. These molecules are typically used to kill bacteria intracellularly. Patients present with recurrent pyogenic infections with catalase positive organisms, just as Staph aureus, with normal concentrations of leukocytes and immunoglobulins. So normal concentration. Here the immunoglobulins are kind of increased. And it's not what were we against? Whiskot. It's caused by mutations in the Y gene on the X chromosome that codes for protein essential for actin cytoskeleton rearrangement. That occurs during interactions between T lymphocytes, B lymphocytes, and antigen presenting cells, leading to impaired innate and adaptive immune system. Um, Patients present with eczema, thrombocytopenia, infections with encapsulated bacteria, and opportunistic pathogen. Okay, so it's HIV. Next.
A 2-month-old boy is brought to the physician for an initial examination because of persistent jaundice. He is described as good baby who breastfeeds reasonably well but often needs to be awakened to feed. Examination shows umbilical hernia, mild jaundice, cold, cool extremity. Growths, growth is appropriate for age. Which of the following is the most appropriate next step in the diagnosis?
Ready?
Ready?
Mm-hmm. It is thyroid function test. Congenital hypothyroidism typically presents without symptoms due to placenta crossing of maternal thyroid hormone. However, if hypothyroidism is left untreated, infant may develop lethargy, hypothermia, feeding problems, hoarse cry, myxomatosis, faces, microglossia, hypotonia, umbilical hernia, prolonged jaundice caused by impaired feeding and decreased bilirubin conjugation, and dry skin. Intellectual disability in a childhood may develop. Diagnosis require evaluation of thyroid function test, which typically shows increased TSH and decreased T4. In patients with decreased thyroid hormone concentration and serum testing, thyroid scans and thyroid binding globulin concentrations help elucidate the cause of hypothyroidism, distinguishing between thyroid dysgenesis and defective thyroid hormone synthesis. Management requires proactive newborn screening and levothyroxine therapy.
Okay.
Okay, next.
A 3-year-old girl is brought to the hospital because of one-day history of fever and irritability with and a 2-day history of diarrhea that has become bloody during the past 6 years. She was born at 39 weeks of gestation. Pregnancy and delivery were uncomplicated. Her diet consists of cow milk based formula. The family occasionally eats out at fast food restaurant. There are two pet lizards at home. The patient is awake but irritable. She is at 25th percentile for length and weight and 50 percentile for head circumference. Her temperature is 39.1, pulse 170 per minute, respiration 40 per minute. Capillary refill is less than 2 seconds. Her hemoglobin concentration is 60 gram per deciliter. Leukocyte count is 18,000. Platelet count is 260,000. Serum concentration, electrolytes, urea, nitrogen, creatinine are the reference ranges. After 24-hour blood and stool cultures grow gram-negative rod. Which of the following is the most likely organism?
Gram negative. Hmm. Ugh, I don't remember which one was it. Shigella is gram negative. And
Salmonella is also gram-negative.
ah, E. coli is also E. coli is also
La-
gram negative.
gram-negative.
And
How
Campylobacter,
you will reach here?
they are
That's the
all. Campylobacter also is gram negative. I think so. Yeah.
yes.
Oh my goodness. Okay. So that's not the point. They all kind of cause bloody diarrhea, except listeria. I don't think listeria causes bloody diarrhea, but all the other ones, yeah, they cause bloody diarrhea. Okay, so ah, but they ate. The baby eats. No, she's 3 week old, so she cannot eat food. Yeah, she
Um,
cannot really eat food.
he
She only
he
ate
died.
cow.
He her diet consisted of cow-based formula.
Cow indeed makes formula. So,
There
salmonella and How is Shigella transmitted again? I forgot.
Shigella causes bloody diarrhea. Heavy.
But how is it transmitted? Through food, through droplet? Why is it? How is it transmitted again?
Yes, it can be like poor sanitation. This thing.
Poor sanitation.
No, no, poor sanitation is not the thing.
But salmonella, I know is the chicken, so I don't think is that. E.
Probability
coli.
of salmonella is higher.
Oh, you think it's higher? Okay. E. coli, but the baby don't eat food. So how is it going to be chicken? And the E. coli is the how do you say it? The meat. So and then Campylobacter is also the meat. I'll go with chicken. I don't know what to. I don't know. Whatever. I don't know about this. Ready?
Yes.
Okay. Oh my God, it's salmonella. Salmonella is a mortal gram-negative bacillus that is major cause of diarrhea worldwide. In the US, it's most associated with undercooked poultry, eggs, and meats. And in some cases has been associated with, oh, it was the pet, with pets like turtles, reptiles, chickens. The incubation period typically ranges from 8 hours to 3 days, and patients will subsequently develop diarrhea, nausea, vomiting,
Like
fever.
how these lizards go into
I
his
don't
stomach.
no,
He eat
I don't think
lizard.
no, I don't think he eats it. Maybe touching it, I guess, like I don't like being
Last
encountered.
hit the baby touch the lizard and put it in his mouth. Like
No, like I don't know, but it's definitely not eating because you're not gonna eat like turtle. I mean, I don't know some people eat it, but it's definitely not touching, and I don't think it's it's definitely not eating. I think maybe just because they are around. I don't know. Either way, just remember that it can be the tortoise and reptiles.
Another thing I am thinking that our diet consists of cow-based formula.
Mm-hmm.
Like if there is like open milk jar or something,
Mm-hmm.
and
Mm-hmm.
the lizard fall and something
Oh
happens,
my
then
god! You
thinking so far,
that's like
thinking
well,
like a detective.
but at this point, just let's just remember that lizards and turtles that they can cause something. That's it. That let's not figure out how, but yeah.
Okay,
Bloody stools are common in children as Salmonella gastroenteritis is usually self-limited with fever resolving within 3 days and diarrhea resolving in a week. Supportive care, including oral hydration, is the cornerstone of management, and antibiotics are not recommended in immunocompetent individuals with no moderate infections or with mild to moderate infections. Study may show gram-negative bacilli. It is not Campylobacter gram-negative rot that's common cause of bacterial diarrhea in the US. Associated with risk factors, travel and consumption of undercooked poultry and meat. Patients often present with watery diarrhea that's self-limited. Oh, I thought it was bloody. Okay. Patients are treated with supportive care and diagnosis is confirmed with by stool cultures. E. coli, the 015, whatever, is associated with sugar toxins and outbreaks of bloody diarrhea. The cause may be complicated by HOS, um, which presents with microangiopathic hemolytic anemia, thrombocytopenia, kidney failure. We know that. It's not listed. We already know it wasn't listed. Shigella is a gram-negative bacillus associated with initially watery diarrhea, which may follow by bloody diarrhea. Patients may also present with fevers, abdominal pain, distension, cramping. Diagnosis is made with stool culture. Antimotility agents are not recommended for affected patients as they may worsen. So Shigella is watery followed by bloody. E. coli, HUS, and meat, whatever. And Campylobacter, I guess, is watery diarrhea. This doesn't make sense. I feel like Campylobacter is what is bloody diarrhea. Campylobacter.
Campylobacter jejuni may be bloody, isn't it?
Oh, bloody, yeah.
And Campylobacter is associated with GBS.
GBS, yeah, and it's bloody. Yeah, that doesn't make. Yeah, I don't know why they say it's watery. Okay, next.
A 2-day old newborn, sorry, a 2-day old full-term newborn is brought to the physician by of bilateral eye discharge. He was delivered at home by his father. He was delivered at home by his father and has not been yet examined by the physician. He appears well, vital signs are within normal limits. Examination shows marked swelling of the eyelid. There is profuse yellow discharge from both eyes. The conjunctiva cannot be visualized because of swelling. No abnormalities are noted. Which of the following is the most likely diagnosis?
Yellow discharge. 2 days.
Profuse yellow discharge.
Yellow, yellow.
Maybe bacterial, isn't it? It is not allergic,
It's
not
definitely
not
allergic.
chemical, not Kawasaki. It is not Kawasaki disease. In Kawasaki fever for more than 5 days. Only 2 days old boy. Either chlamydia or gonorrhea.
Chlamydia, not over.
Mm,
Profusely. Maybe I thought it's chemical because I feel like chemical was between, I think, 5 days. Was it 5 days? I think. I don't know. It was something in a newborn. But I don't know if the newborn had to be born at the hospital. Anyway, let's check. Ready?
yes. What have you picked?
Chemical. Oh, never mind.
I don't think so. Okay.
Gonococcal. Gonococcal conjunctivitis result of direct inoculation of bacteria from the genital canal to the newborn's eye during process of delivery. Patients present with redness, profuse purulent discharge, eyelid swelling, lymphadenopathy. Gram stain of purulent discharge will show gram-negative diplococci. In the hospital setting, erythromycin drops are provided to newborns at the time of delivery to prevent gonococcal conjunctivitis. Um, okay. Newborns diagnosed with gonococcal conjunctivitis should be hospitalized. Culture should be obtained, and patients should be provided ceftriaxone. Patients may also be provided artificial tears until the condition is improved. It is not chemical, may be the result of chemicals meeting the conjunctiva. Symptoms including redness, pruritus, pain, and watery discharge may be present. In general, once the chemical has been washed out from the eye, symptoms improve. Chlorine is common self-limited cause of chemical conjunctivitis. Okay. Chlamydial conjunctivitis typically occur like 5 to 14 days following delivery and presents with unilateral presents with initial watery discharge that becomes mucopurulent over time. The conjunctiva may become friable and produce bloody discharge. NAT tests are gold standard for diagnosis. Treatment should only be started in infants who test positive for the condition. Erythromycin is the preferred agent of choice for neonatal chlamydia. So neonatal watery, the other one purulent, yellow. Okay.
Chlamydia is mucopurulent, and as it
No.
shows, sorry,
Oh, chlamydia is watery.
sorry, initial watery that becomes mucopurulent over time.
Okay.
Fine. Okay.
Oh, and chlamydia is like 5 days to 14. So it wouldn't be, this one is 2 days old. Chlamydia is like five
It
days to
starts from 5 days. Okay. And gonococcal erythromycin treatment. Erythromycin. Okay.
no. Gonococcal treatment is not erythromycin. It's prevention erythromycin. Treatment ceftriaxone or whatever. Uh, Cephalosporin, sorry.
Okay. A 22-month old boy, a 22-month-old boy has had fever, vomiting, diarrhea for 3 days. His mother has been supplementing his usual diet with extra non-dairy liquids, extra non-dairy liquids during this period. He has had 12 to 15 diarrheal stools each day. She says that it is difficult to distinguish stool from urine when she changes his diaper. Her temperature is 100.2 degree Fahrenheit. Pulse is 120 per minute. Respiration 32 per minute. Lab studies sodium 135, chloride 115, potassium normal, bicarbonate low. Bicarbonate is very low, chloride is high. Urine pH may be normal. ABG pH is low 7.28, acidosis. PCO2 low, bicarbonate is very low, oxygen is higher. Acidosis. Which of the following is most likely explanation of her acid-base disorder?
Metabolic acidosis. So there's to the anion gap, which would be chloride plus 115 plus 20. Uh, plus 20 plus 10. 45. So it will be 10. So it will be low. Oh, does it continue? No, it doesn't continue. Um, Okay. Ready?
Ready?
Yeah. No, what happened? Okay, so is where is it? Stool losses of bicarb. So diarrhea basically. This patient lab studies an arterial blood vessel non-anion gap metabolic acidosis with partial compensation. NAGMA is identified by pH less than 7.35 acidemia with decreased PCO2 and bicarb. The respiratory symptom compensates for the acidosis by increasing minute ventilation, which eliminates carbon dioxide and acid. This results in decreased PCO2 and increased pH back to normal range. This patient persistently decreased pH suggests that respiratory compensation is only partial. Metabolic acidosis describes a derangement involving excess acid and is subdivided into anion gap and non-anion gap category. Anion gaps, sodium minus chloride plus bicarb calculation measure, whatever, which are contributing to the acidity, whereas non-ion gap generally results from excess supply of protons or chloride retention of protons or chloride by the kidney or failure to secrete bicarb buffers. Non-NAGMA is often a hyperchloremic metabolic acidosis as seen in this patient. Causes of NAGMA include infusion of normal saline, Addison disease, RTAs, diarrhea. In the case of diarrhea or GI disturbance, such as in this patient, bicarb secreted in the small intestine is normally reclaimed in the large intestine in exchange for chloride ions. If the colon cannot reclaim bicarb, such as following colectomy or during diarrheal illness, the concentration of serum chloride will remain increased and serum bicarb will decrease. Okay, next.
Ready?
Mm-hmm.
Okay. A 5-day-old newborn hemorrhagic disease due to vitamin K deficiency. There is bleeding from the nose, mouth, GIT in the subdural space. In addition to vitamin K therapy, which are following is the next step. Uh, Okay. Is it FFP or cryoprecipitated? It is acute bleeding, isn't it?
Acute bleeding. So you give them vitamin K, I guess fresh frozen plasma. Okay, let's see. 31, 31. Fresh frozen plasma. Vitamin K is a fat soluble vitamin that plays an important role in the synthesis of various coagulation factors like 2790, as well as protein C and S. Primary sources of vitamin K include leafy green vegetable endogenous production by intestinal bacteria. Vitamin K deficiency is common in newborns due to poor placenta transfer of vitamin K, low concentration of vitamin K in the breast milk and immature neonatal intestinal flora, and poor absorption. Vitamin K deficiency presents with signs and symptoms of bleeding, also known as hemorrhagic disease of the newborn, which may include cutaneous bleeding like bruising, petechia, oozing from venipuncture sites, hematomas, epistaxis, GI, retroperitoneal, intracranial hemorrhage. All newborns should be administered prophylaxis with intramuscular vitamin K. Newborns with evidence of bleeding should be treated with oral or IV replacement of vitamin K and fresh frozen plasma, although treatment should be tailored according to the type and severity of bleeding. FFP contains all coagulation factors as well as fibrinogen and protein C and S. It's not cryoprecipitate, contains concentrated fibrinogen along with factors as at 8 and 13 and von Willebrand factor. It's commonly used for the treatment of coagulation states with decreased concentration of fibrinogen um, and factor 8, such as DIC. Carbohydrates does not contain the coagulation factors that are affected by vitamin K deficiency, such as 2, 7, 9, 10, and protein C and S. So it only contains factor 8 and factor 13 and von Willebrand factor. Okay.
Ready?
Next. Mm.
Next. A 5-week-old girl is brought to the emergency department because of one day history of vomiting immediately after each feeding. During this time, he has had only two wet diapers. He was born at term during an uncomplicated pregnancy delivery and weight is 3.3 kg. He was exclusively breastfed during the first 3 weeks of life. The first 2 weeks has diet consists of cow-based formula. Now he has been thinking. Sorry, now he he has been taking 4 to 5 hours per feeding until yesterday and minimal spitting after each feeding. At his most recent examination 1 week ago, his weight is 4.2 kg. He weighs 85 gram less. Physical examination show no abnormality. After the examination, he is given a bottle of formula drink 4 hours and vomits a large amount. Which of the following is the obstruction? It is not bilious vomiting, isn't it?
They didn't say anything about the volume vomiting.
Okay.
Okay. So it is pyloric junction, I guess pyloric
Pyloric
stenosis.
stenosis.
Disorder of the pyloric sphincter that occurs in young infants and can result in partial or complete gastric outlet obstruction is caused by hypertrophy of the pylorus and inability to relax the sphincter. Infants classically present within 1 to 2 months of life with forceful non-bilious emesis. Physical exam notable for a characteristic ovoid mass in the epigastric region. The recurrent emesis, if severe, may result in signs of volume depletion and malnutrition. Lab studies typically show hypochloremic, hypokalemic metabolic alkalosis as a result of loss of gastric hydrochloric acid and potassium ions. Additionally, the resultant volume depletion causes activation of the RAS, resulting in renal losses of potassium and protons. Confirmatory diagnosis is made by ultrasound imaging to evaluate thickness and length of the pyloric muscle. Patients are treated with surgical pylorotomy to relieve the stenosis. Okay, next.
Okay. A 4 month old a 4 month old female infant is brought to the physician because of rash in his diaper area for 5 days. The infant has 2 episodes of otitis media treated with oral antibiotic therapy but has been otherwise healthy. Her temperature is 37 degrees Celsius. Physical examination shows a red confluent rash with a sharply demarcated border, pustules, and satellite papules on the diaper area. Which of the following is the most appropriate therapy?
Oh, already? Sorry.
Yes.
Yeah. So is topical nystatin. Topical nystatin Pauline is a Pauline that is used topically to treat mucocutaneous candida infections. Candida is part of the normal mucocutaneous flora. But the infection is common in intertriginous areas like diaper area in infants, along with the genital and inframammary regions in adults. Candida infections may be associated with beefy red patches favoring the skin folds with satellite papules and pustules. First line is topical antifungal such as nystatin. Again, mopirocin, I think you told me yesterday it was to use to treat
Impetigo,
impetigo. I always forget
honey
that.
crusted lesion.
Any custard lesion. Yep. Next.
Okay. A 2-year-old boy who is HIV positive is brought to the family clinic by his mother for a follow-up examination. He is currently taking 3 antiretroviral therapy. His HIV positive mother is also taking multiple antiretroviral therapy. She has chronic cryptosporidiosis and has 5 kg weight loss during the past 4 months. The mother is not in contact with the family. The child's growth and development are appropriately for age, and immunizations are up to date. Examination shows two small non-tender mobile lymph node in the right axilla. Lab studies show leukocyte count 12,800 in children and 4,100 in mother. Lymphocyte 55% and in mother 80%. Monocyte is 35%, 10%. Monocyte is 10%. Both CD4 T lymphocyte count in children is 1852 and in mother it is low. Plasma HIV load is undetectable in case of mother 38,000. Serum hepatitis C antibody negative. In case of mother it is positive. Which of the following is the most appropriate topic to discuss at this visit?
I don't know. Ready?
Okay.
Okay, so it will be care of the child in case of the mother's death. Jesus. In addition to caring for the physical and mental well-being of a child, part of the role of a pediatrician is to help navigate difficult social situations that may be impacting the lives of the patients. Based on these labs results showing a normal CD4 count and undetectable viral, these patients appear to have well-controlled HIV. However, despite taking multiple antiretroviral drugs, his mom has a dangerously low CD4 count and persistently increased viral load and is at high risk of dying from AIDS-related complications. With a father who is not participating in this child's care, it is important that the mom to have a plan in place for who will take care of the child after her death. As a child with HIV, this patient will require lifelong antiretroviral medication and close follow-up with his pediatrician and infectious disease doctor, and will need a caretaker who's aware of these needs. Although the conversation may be difficult, a pediatrician should initiate these discussions to ensure the patient will be taken care of and offer resources to the mom if needed. It is not long-term. What is it? The advantage or whatever. Long-term complications of HIV infection are all important things to discuss at some point. While these are important topics, the more pressing matter at this time is the care of the child after the mom death. Okay, next.
Okay. A 2-day-old female newborn is examined before being discharged home. She was born at she was born at term following uncomplicated pregnancy and spontaneous vaginal delivery. She is at 50 centimeter in length, 35.3.5 kg. Her temperature is 36.8. Pulse 128 per minute, respiration 38 per minute, blood pressure is 75/40. Examination showed generalized rash with small yellow papules and erythematous base predominantly over the trunk. Which of the following is the most appropriate next step in the management?
Ready?
Okay,
Okay, so it's reassurance that the parents that the rash will resolve in a few days. Erythema toxicum neonatorum is a common benign skin eruption of newborns that typically begins in the days following delivery and lasts for from hours to days. This condition is characterized by 1 to 2 millimeter pale to yellow papules or pustules with erythematous base. Typically found on the trunk, diagnosis is made based on clinical presentation. If performed, a bedside right stain of vesicular fluid will show numerous eosinophils. The assurance that the rash will resolve in a few days following diagnosis should be provided to the newborn parents. Erythema toxicum in its isolation follows a benign and harmless course. It is not herpes. Will be the appropriate step for suspected cutaneous herpes simplex. Herpes simplex generally presents as group umbilicated vesicles on the lips, genitals, or any location on the skin. In newborns, the diagnosis raises concern for disseminated HSV, for which there is a low threshold to obtain a lumbar puncture, initiate a cyclovir to prevent and treat meningitis.
okay, okay. Let's take a 5-10 minute.
For recent test takers, like the length of the question, did they feel like people that said that people used to say that the people say that it's similar to the CMS, but do they also mean like the length of the question is similar to CMS? Because CMS has like short, a lot of short like questions. And then somebody replies, it was like, just took the test yesterday, and the length was more similar to 3120 MBME 14 and 15. So yeah.
Okay, so NBA 14 and 15 is important.
Yeah. So I don't remember what was the length on those two, but
We have to solve those two. Okay, a, a 5-week-old child is brought to the emergency department by his parents in the fall because of 2 week history of progressive cough. He often coughs uncontrollably until he is struggling to breathe and vomit. He has not had fever. He has moderate nasal congestion for the past 5 days of illness. He was born he was born following uncomplicated pregnancy and the delivery. The patient's father also had a cough for 3 weeks. During the examination, the patient is not in distress except when he is coughing. He is at 25 percentile for length, weight, and head circumference. Temperature is 37.1 degrees Celsius. Pulse is 148 per minute. Respiration 40 per minute. Pulse oximetry on room air shows oxygen saturation 95%. The lungs are clear to auscultation. The remainder of the examination show no abnormality. Labs show leukocyte of 28,000, segmented neutrophil 14%, band 1%, lymphocyte 80%, monocyte 5%. A chest X-ray shows no abnormality. Which of the following is the most likely causal organism?
Ready?
Ready?
Mm-hmm. So
Okay.
it is Bordetella. Cases of severe paroxysmal coughing in the setting of respiratory illness concerning for pertussis. Pertussis occurs as a result of the infection with Bordetella. Classically present three stages. Catarrhal stage is the first, which presents with fever, rhinorrhea, and mild cough. It progresses to the paroxysmal stage after 1 to 2 weeks, in which the patient experiences violent um, bouts of extreme coughing at times following times violent enough to cause secondary traumatic injuries such as rib fractures, urinary incontinence, and pneumothorax. Often such coughing fits are accompanied by cyanosis, which it may be followed by syncope, emesis, or apnea. The paroxysmal stage can last for weeks to months. Symptoms resolve during the convalescence stage, which lasts like from 1 to 4 weeks. Pertussis can be prevented by immunizations in the form of acellular pertussis, typically given with tetanus and diphtheria. It's treated with antibiotics like macrolides and supportive care. Next.
Yes. A 17-year-old boy comes to the office for examination prior to participating in football. The patient says he feels well, he has no serious illness, takes no medication, there is no family history of serious illness. The patient is 5 feet 11 inch tall, weight is 93 kg, BMI is 29, blood pressure in the right upper extremity, obtained by automated oscillometric device 138 by 88 millimeter of mercury. Repeat blood pressure by the device is 140 by 89 millimeter of mercury. Examination shows no abnormality. Which of the following is the most appropriate next step in the diagnosis?
Ready? Ready?
Sorry,
Ready? Sorry.
your sound is very low. That's why I am
Oh,
unable to hear.
sorry.
Okay.
Ready?
Yes.
I don't know why.
Okay.
Blood pressure measurement by auscultation. Hypertension is an increasing finding among pediatric and adolescent patients as rates of obesity has risen. Childhood and adolescent hypertension is associated with both an increased risk for persistent hypertension during adulthood and increased risk for adverse cardiovascular events later in life. In adolescent patients, hypertension is defined as BP greater than 95 percentile. Accurate blood pressure measurement is essential for staging and aids in guiding treatment and BP recheck intervals. Oscillometry devices are commonly used for hypertension screening and routine office measurement, but frequently overestimate both systolic and diastolic blood pressure. If initial measurement by oscillometric, what is that? Oscillometric device reading is high. Repeat,
Is it the
uh,
automated blood pressure machine that is oscillometric
I don't
device?
know.
I haven't seen.
I never heard that word.
Like there is automated blood pressure machine. Is it oscillometric?
Oscillometric um, BP device. Oh no, oh no, it don't look like anything. Oh, oh, what is it?
Open the video, then we can understand.
This one? Oh,
Yes, oscillometric blood pressure. This is automated. Look at the normal, like manual blood pressure machine.
so that's what
So,
they mean by the manual one.
like this kind of blood pressure machine, which is not you. where you do not need the physician. You got my point. Okay, I understand what they are trying to mean.
What are you trying to say?
Like the blood pressure machine, this type of blood pressure machine, like where you just put the cuff and
Uh-huh.
you got an answer that BP is 130 over 90. But if you,
Like this. Uh-huh.
yes, this one, they will automatically give you the blood
Yeah.
pressure measurement by oscillation, by oscillation your artery and vein, like oscillation of the arterial issue. But if you put an stethoscope after putting an BP cuff and hear the systolic and diastolic sound, the sound may differ.
Okay. Okay. Got it. In adolescent patient, hypertension is defined whatever. Accurate blood pressure measurement is essential, whatever. Oscillometric devices are commonly used for hypertension screening and routine measurements, but frequently overestimate both systolic and diastolic BP. If initial measurement by oscillometric device reading is high, repeat measurement by auscultation should be performed in average to determine the patient's stage of hypertension. Initial treatment of hypertension is lifestyle modification targeting modified like obesity. It is not what is it? A repeat BP measurement by oscillometric device in the office, either daily for the next 3 days or in 2 weeks, is incorrect. Oscillometric devices frequently overestimate BP, and confirmatory measurements by auscultation are required for diagnosis. Okay, next.
So in case of adolescent, we for if BP is high in oscillometric device, we should recheck by auscultatory method.
Mm-hmm.
Okay. A 3-year-old boy is brought to the emergency department 4 hours after the onset of irritability, and temperature is 40 degrees Celsius, 100.4 degree Fahrenheit. He received the diagnosis of the systemic GIA 2 months ago. Treatment with ibuprofen has begun to improve his joint stiffness and swelling. He appears pale and inconsolable. Examination shows scattered petechiae over the trunk and the extremity, and the distended abdomen and diffuse lymphadenopathy. The liver, age, and spleen are palpated 5 centimeter below the costal margin. There is bilateral knee and ankle swelling with effusion. Hematocrit 23.4%. Leukocyte 2500. Segmented neutrophil 20%. Band 10%. Lymphocyte 70%. Platelet count 45,000. ESR 12. AST 235. AST 235, ALT 337, CRB 3.5. Which of the following is the most appropriate next step in the diagnosis?
High temperature.
Still, it is high. Platelet count is low.
Everything kind of seems slow. Hematocrit low, leukocyte count not
Low.
low, platelet low, and then juice.
Temperature is
Marrow aspiration. What else? Liver biopsy. Why?
systemic GI2.
Bone marrow.
Is it macrophage activation syndrome?
What? I never.
In systemic GI, there is one thing called macrophage activation syndrome.
Macro. I never heard that. Pale and inconsolable. Okay, because he's okay. His hematocrit is low. And then petechiae, blah blah blah. Distended abdomen. I don't know. Abdominal CT. I would have done bone marrow aspiration, but I felt like it wouldn't be the next step. maybe. I don't know. Ready?
Yes.
So it's bone marrow asphere, I guess is the next step. This patient with fever, petechia, lymphadenopathy, hepatosplenomegaly, lab findings of pancytopenia has presenting concerning for ALL. Oh, is
No,
a
it's
common
ALL.
ALL is a common did go from
We
okay.
actually forgot that ALL can happen.
Yeah, but it's because they were talking to us about the GIA, so I just never. Okay. ALL
Yes,
is a
there was hepatosplenomegaly. We completely skipped.
pediatric malignancy of B and T lymphocytes that may present with malaise, fatigue, weight loss. Splenomegaly, lymphadenopathy, anemia, thrombocytopenia with circulating leukemic blasts on peripheral blood smear. Diagnosis is confirmed with bone marrow biopsy showing more than 20% lymphoblasts. B lymphocyte malignancies are more common than T lymphocytes. And evaluation with flow cytometry is necessary to determine the specific type of malignancy, followed by mutational analysis. Treatment typically entails chemo, and many patients with AL will enter remission. Bone marrow transplant can be curative. Many cases, it's not abdominal CT can be performed to identify intra-abdominal tumors such as neuroblastoma and nephroblastoma. These patients' hepatosplenomegaly is likely secondary to leukemia rather than primary intra-abdominal pathology. It is not, I guess, bone scan. The type of bone scan that uses the titanium 99 to evaluate the presence of osteoblastic osseous metastasis, most commonly detected of breast and prostate cancer. Okay.
Next, a 7-year-old boy is brought to the emergency department because of acute onset of pain of the acute onset of the pain on the pain over the anterior surface of the neck. The pain is exacerbated by swallowing or sticking out of his tongue. He also has 1 day of fever and chills. Examination showed tenderness in the midline over the trachea in the region of thyroid isthmus. There is cervical lymphadenopathy. He has scratches on his arm playing with his 4-year-old cat. Which of the following is the most likely diagnosis? So,
Hmm. They say cat and I'm like cat scratch disease, but I didn't even look at the symptoms. Um,
okay.
have pain with swallowing and the cat scratch doesn't make sense.
Yes,
Uh,
that doesn't make sense.
the pain with the with swallowing and all that doesn't make that much sense. And then cervical lymphadenopathy doesn't. I thought they had the things in the skin.
Cervical lymphadenopathy, the lymphadenopathy can go with the infectious mononucleosis.
Lymphaden. Yeah,
But
but infection also
but
has the
uh, there is another problem. There is uh, like the pain is exacerbated by swallowing or sticking out of the tongue.
so you think it's infected thyroid. No. I'm going in between cat scratch and infectious mononucleosis.
It's not castrus.
It's not cat scratch. Okay, then it's infectious mononucleosis probably. Yeah. Okay, so it is in. Oh my lord, never mind. It was infected thyroglossal duct. The findings of fever, chills, chills, and midnight neck pain that worsens with swallowing or sticking out the tongue. Oh, is more suggestive of infected thyroglossal duct cysts. Thyroglossal duct cysts are a common congenital abnormality that results from failure of the thyroglossal duct to close after the embryonic migration of the thyroid, from where it forms in the foramen cecum to its anatomic position in the neck. The thyroid begins to form in the third week of gestation as an outgrowth from the pharynx at the junction between the anterior two-thirds and posterior third of the tongue. It then descends along the thyroglossal duct, passing anterior to the thyroid to the hyoid bone and stopping in the midline neck. The thyroglossal duct then closes. If a segment of the duct persists, epithelial secretions result in cyst formation. Catch disease caused by infection with the gram-negative pleomorphic Cucobacillus bartonella hence acquired via bites or scratch from cats. It most commonly causes localized lymphadenitis along the lymphatic drainage route proximal to the scratch. The axillary and cervical lymph nodes are commonly affected, though the patient has exposure. His presentation is not consistent with catch-grass disease. Infectious mononucleosis, commonly by EBV, those cytomegalovirus and acute HIV infection can also have similar presentations. Patients typically present with lymphadenopathy, most often involving the cervical chain, pharyngitis, fatigue, splenomegaly. These patient examinations are more consistent with infected thyroglossal duct. Never mind. Next.
A 6 months old girl A 6 months old girl with Beckwith-Wiedemann syndrome is brought to the physician because of 1 week history of intermittent vomiting and fuzziness. 1 week history of intermittent vomiting and fuzziness. She receives no medication. Vital signs are within normal limit. Examinations show macroglosia and right-sided hypertrophy. On abdominal examination, mass a firm mass is palpated on the right upper quadrant. Lab studies show beta hCG 0, alpha fetoprotein is high, 15,678, urine homovalenic acid is 10, and vinyl mandelic acid is normal, 5.6 gram per gram. Abdominal examination is noted. Which of the following is the most likely explanation for this patient's mass?
Ready?
Yes.
Uh, So it's hepatoblastoma. Beck-Whittenham syndrome is a genetic disorder involving mutations of any of several genes located at the chromosome 11 locus that may result from a variety of mechanisms, including defects of imprinting of unilateral disomy. Beck-Whittenham syndrome is characterized by cellular overgrowth and a predisposition to the development of malignancy. Mm, Its presentation is heterogeneous but commonly includes an above average birth weight, macrosomia, macroglossia, visceromegaly, kidney malfunctions, omphalocele, umbilical hernia. Children with Beck-Whittenham um, children with Beck-Whittenham syndrome are at an increased risk for developing a variety of malignancies such as Worm's tumor, hepatoblastoma, alpha fetoprotein concentrations are increased in most patients with hepatoblastoma. Small germ cell tumor would not present as a form of abdominal mass. York sac tumors, a type of germ cell tumors, may present as a pelvic mass in young children and are associated with increased serum alpha fetoprotein. Okay, next.
A 12-year-old girl with chronic sinusitis is brought to the physician because of fever and productive cough for 4 days. He had pneumococcal pneumonia 5 months ago, was treated with IV ceftriaxone followed by amoxicillin. She is at 50 percentile weight and height. Temperature is 102, pulse 105, respiration for 30 per minute. Uh, Breath sounds are decreased on the lower right. Lab studies leukocyte count 21,000, segmented neutrophil 70%, band 15%, lymphocyte 15%, CD3 normal, CD4 normal, CD8 is also normal. IgGAM, is it low or normal?
Let me check. So all the CDs are normal.
All the CDs are normal, yes, that's true.
Uh, IgA 76 to 3 is low. IgA is low. IgG is low too. And then IgM is also low. They are all low.
So now we have two things, X-linked agramaglobulinemia and CVID.
Wait, we said T is fine and B has the problem.
Sorry,
Um, so we said so T is fine, all the T lymphocytes are fine, and so the problem is B lymphocytes, and she's 12 years old.
yes.
So it cannot be.
X-linked.
Oh, X linked I guess will be a male, right?
X X-linked.
I don't know.
Is there anything like that? I don't know.
No.
I
This
think that uh, X-linked for babies and CVID for 12 years.
yes. X linked was for baby and CVID was, yeah, I think so too. Yeah.
Male, female, I don't know actually.
Don't remember so I don't know. I just saw X link. Don't follow me on that one. Okay, let's check. Yeah, it's CVID. Most likely diagnosis for this patient, CVID. The exact cause of pathogenesis are unknown. However, the disease is characterized by combined T and B cell defects, huh? T and B lymphocyte defects, dysfunction in B lymphocyte differentiation, and a decrease in serum concentrations of all immunoglobulin, as seen in these patient lab studies. Commonly presents in the second to fourth decades of life with recurrent upper respiratory infections, pulmonary and GI infections. Patients may develop bronchiectasis as a result of recurrent airway infections and inflammation. CVID is also associated with persistent diarrhea as a result of giardia. Physical exam may show lymphadenopathy and splenomegaly. The mainstays of treatment include IV immunoglobulin replacement therapy and antibiotics. CVID is strongly associated with lymphoma, an autoimmune condition. It is not X-linked. Dermatoglobulin is caused by mutations of the BTK gene that encodes tyrosine kinase, essential for all stages of B lymphocyte development and proliferation. Patients lack function in B lymphocytes and therefore lack normal concentration of immunoglobulin. Nearly always presents within the first 18 months or year and a half of life. With recurrent infection is more common in males. Oh, there you go. That's why even the X-linked inheritance. So X-linked for males in first year of life.
Okay,
Oh, I want to transient aga whatever glomerulonephria of infancy, primary immunodeficiency syndrome characterized by drop in IgG concentrations greater than expected physiologic hypogammia that naturally occurs as maternal antibodies. Okay. Patients may present with recurrent bacterial infection. IgA and IgM concentrations are normal, and then IgG returns to normal concentrations by age 6 years old. Okay, next.
an 8-year-old girl is brought to the physician because of her parents are concerned that she is different from their older child and prefers to be alone instead of socializing with peers or family. She carries a doll she found at a yard sale wherever she goes, but never plays with it. Whenever she is Without the doll, she becomes distraught and has a tantrum. The patient once invited a girl from the daughter's class of their home, but the patient appeared disinterested and would not play with other girls. The patient's teachers report that she is often tasked and distracted in the second grade class, but she answers direct questions. She does not participate in games and recesses. She tends to drift off by herself, wander about the playground. She is 50 percentile for height, 30 percentile for weight, 90 percentile for head circumference. Physical examination shows no abnormality. During the examination, the patient holds an undressed doll by its feet. He makes a little eye contact. She occasionally repeats the physician words instead of answering the question. Which of the following is the most likely diagnosis? Looks like autism.
You
Or
think?
or you are
Yeah,
thinking,
yeah, yeah.
what is your thought or what is your diagnosis?
No, I don't have a diagnosis here. I don't have a diagnosis. But yeah, I mean, yeah, because she has the doll that she doesn't let go away. Yeah, I guess yeah, that would be
I
autism.
told one day to you, oof, I missed that.
What? Let me see.
What you have picked?
Oh, oh, the other name that you show
Yes,
me. You show it to me one day. Yeah, yeah, yeah,
I
yeah,
told you one day, and I
yeah,
still missed.
yeah. You did show me then. Yeah, some point. Pervasive developmental disorder, which has been reclassified as autism spectrum disorder. Wait, so they changed from pervasive developmental disorder to autism, but they still call it, I don't know. Includes a group of neurodevelopmental neurodivergent syndromes that are characterized by typical forms of social communication and interaction. Autism, oh, ASD include autism, Asperger's syndrome, childhood disintegrative disorder, pervasive developmental disorder not otherwise specified. Oh, autism spectrum disorder is characterized by a broad range of signs and symptoms involving restricted and repetitive patterns of behavior and activities. Children with autism often display decreased interest in socializing and may have challenging behaviors conflicting with established societal norms. Children may also display a narrow and focused range of interests, an increased reliance on routine and apprehension to change or unexpected circumstances. The clinical manifestation of ASD typically present within the first 2 years of life with an observed delay and regression of communication and social skills. These typically includes decreased nonverbal communication such as eye contact, facial expressions. Management of ASD is individualized depending on the clinical manifestations and um, degree of social distress of the patient. Therapy involves behavioral development, social and educational interventions to improve social functioning. Yeah. Learning disorder is not likely for this patient. Learning disorder are characterized by persistent impairment in reading, writing, written expression of mathematical ability. Patients may have difficulty with specific skills relating to these subjects. Learning disorder may coexist with ASD. Mild intellectual developmental disorder refers to mild impairment related to abstract or theoretical thinking. And patients may also have decreased social and daily functional skills. They are typically able to adapt to living in society with life skills training in specific areas. Don't understand the mild one. Okay, next.
A 10-year-old girl is brought to the physician by her mother 3 hours after she refused. 3 hours after she refused to get out of bed this morning. Over the past 4 days, she has had fever, malaise, severe pain in her elbow, wrists, and knees. The family recently lived in a refugee camp. She appears flushed and acutely ill. Her pulse is 110 per minute, respiration 20 per minute, blood pressure 100 by 40 millimeter mercury. The knee and ankle joints are warm and swollen. A grade 4 by 6 hollow-crystalline murmur is heard at the apex, radiates to the axilla. Which of the following is the most likely diagnosis?
Mm, and help us recently, and the family live in a refugee camp. Lyme disease.
Why murmur?
Mitral regurgement, dengue fever. It's not dengue, it's not malaria.
Yes,
Uh,
apart from rheumatic fever, anything does not match. Like
type.
in rheumatic fever, there may be murmur, but there is should be a history of sore throat.
Why is it not Lyme? Oh, Lyme is AV block. Sorry. Never mind. Yeah, I
Lyme.
guess. We are a refugee. Yeah, I guess it's rheumatic fever. That's the only thing that makes sense.
Okay,
I don't
let's see.
remember this kind of fight. I don't remember
Lyme
typhoid.
disease, yes, heart block.
Yeah,
And
rheumatic.
okay,
The most likely diagnosis rheumatic fever characterized by arthritis and murmur suggestive of mitral regurg. Rheumatic fever is sequela of strep A infection, commonly pharyngitis, in which there is type 2 hypersensitivity reaction to self-antigens having a similar structure to and molecular mimicry of the step M protein. Diagnosis is made by Jones criteria, which describe many of the core clinical features of rheumatic fever, including polyarthritis, carditis, subcutaneous nodules, erythema marginata, and sedum chorea, as well as minor criteria like fever, leukocytosis, arthralgia, and PR interval prolongation. Patients often have an increased antistreptolysin titer. Complications of rheumatic fever include mitral valve inflammation, leading to long-term sequelae of mitral valve regurgitation, prolapse, and stenosis. Treatment of initial strep infection is effective for reducing the risk of rheumatic fever. Per the American Something Association, once rheumatic fever has developed, treatment includes salicylates and a prolonged course of monthly penicillin treatment to reduce the risk of recurrence and further yeah. It is not Lyme. It's a tick-borne disease caused by the. It's a tick-borne disease caused by Borrelia, and characteristically causes erythema migrans, an expanding rash that may have central ring scarring. Later stages of Lyme can be associated with carditis, AV block, facial nerve palsy, which may be bilateral, migratory arthralgia, and if less untreated, encephalopathy and chronic arthritis. Typhoid fever caused by gram-negative bacillus Salmonella typhi, and typically present with fever or abdominal pain and non-bloody diarrhea. Physical measure characteristic rash or small red macules in the trunk and extremities. Okay, next.
a previously healthy 7-week-old girl is brought to the emergency department by her parents because of 3-day history of progressive vomiting. 3-day history of progressive vomiting. Her symptoms begin with spitting up, spitting up after every feeding. Now she has forceful vomiting. Her mother says that she has seemed hungry during the period. She has not had fever or diarrhea. She is alert, appears well hydrated, temperature is 37.4 degrees Celsius, pulse 120 per minute, respiration 28 per minute, hemoglobin 9, leukocyte count 8,500, segmented neutrophil 50, lymphocyte 45, monocyte 5%, platelet count 360,000, sodium is 138, chloride 90, potassium 3.6, bicarbonate 36, blood urea nitrogen 25, glucose 70, creatinine 0.3. Which of the following is the most likely diagnosis?
Between pyloric stenosis and viral gastroenteritis, but she says she doesn't appear sick. She appears well and hydrated. Yeah, then it's probably pyloric stenosis. Okay, ready?
Yes.
Okay. So it's pyloric stenosis, disorder of the pyloric sphincter that occurs in young infants. It can result in partial or complete obstruction of the gastric outlet. It's caused by hypertrophy of the pylorus, inability to relax the pyloric sphincter, presents first 2 months of life, forceful non-venous vomiting, physical exam, not ovoid mass in epigastric region, recurrent vomiting, if severe, may result in signs of volume depletion and malnutrition. Lab studies typically show hypochloremic, hypokalemic, metabolic alkalosis, caused by loss of gastric HCl and potassium. Additionally, the resultant volume depletion causes activation of RAS, resulting in loss of potassium and protons. Confirmatory diagnosis, ultrasound to evaluate thickening in treatment is pylorotomy. It's not acute viral gastroenteritis present with vomiting and diarrhea with or without fever. This patient with progressive and force of emesis occurring only after feedings have presentation most likely of gastric outlet obstruction. Okay,
Okay.
yeah.
A 17-year-old girl comes to the physician because of 5-day history of non-tender lesion on her vagina. She is sexually active with 3 male partners and they use condoms inconsistently. Her temperature is 37.2, pulse 78 per minute, respiration 18 per minute, blood pressure 106 by 68. Examination showed 2 by 2 ulcerated lesion with raised border over the labia majors. Which of the following is the most likely causal organism? Ready?
Yeah. Spirochete syphilis, STI from spirochete treponema pallidum that can present in multiple stages. Primary syphilis present with painless chancre, ulcer on the genitalia. There are typically no systemic signs and symptoms of syphilitic infection at this stage. RPR can be falsely negative in the primary stage of syphilis. Dark field microscopy of fluid from the chancre is the most sensitive test for diagnosis of primary syphilis. The treatment for primary syphilis is a single penicillin G intramuscular injection. This testing and treatment for additional STIs is appropriate. They often co-infect. Next.
A 12-year-old boy is brought for a well child examination. Since his last visit 1 year ago, he has had no illness. Pulse 102 per minute, respiration 21 per minute, blood pressure 102 by 60. Examination shown no abnormality, urine analysis 3 plus protein. Which of the following is the most appropriate next step in the diagnosis? Is it nephrotic syndrome?
No, I don't think so. He doesn't have hypertension.
Nephrotic
Oh, sorry.
3 plus protein,
Yeah, no, but he has no other.
no edema, no swelling, nothing present.
I don't think it's nephrotic.
Well child exam.
Hmm.
Why there is 3 plus protein?
There is those transient proteins for the kids, transient proteinuria or something. Sorry, I'm reading renal right now, so that's why I don't
Okay.
remember.
So repeat urine analysis at bedtime and awakening.
I think so. I don't know. I think so because I
Okay.
just read something similar. Okay, let's see if I'm reading right. Yeah, I'm reading right.
Okay.
The first approach in assessing incidentally found proteinuria in a healthy asymptomatic child is to repeat urinalysis. The most common cause of proteinuria in asymptomatic children is transient proteinuria, secondary to other causes such as fever, stress, exercise, dehydration. In addition, proteinuria can be orthostatic or postural with increased protein in standing or upright position. That normalizes when a patient is supine. Orthostatic proteinuria is common in adolescent males, so repeat urinalysis on awakening will likely show normal urinalysis. And a urinalysis at bedtime will show proteinuria. In a patient with persistent proteinuria, further workup should be done to evaluate kidney disease. IV pylography involves the IV injection of radiopaque contrast to visualize the renal collecting system, ureters, and bladder on the fluoroscopy. This allows for investigation of suspected urinary tract abnormalities, malignancies, and strictures. And it's not C. Wait, what else I see? Renal ultrasound is useful in the evaluation of obstruction, abscess, tumor, or cyst, or repeat urinalysis, or whatever. Okay, never mind.
Okay. Unhealthy 16-month-old girl is brought to the physician because of a painless right-sided limb since she began to walk 4 months ago. She was delivered at term by cesarean section. Because of breech presentation, there is no family history of musculoskeletal disorder. Examination shows lower extremity. Examination shows a lower extremity that is shorter. Examination shows a lower extremity that is shorter than the right. Sensation, circulation, muscle strength, and normal abduction of the left hip is limited to 30-degree. Examination of the right hip is shows no abnormality. Which of the following is the most likely underlying mechanism of this patient?
Hmm.
16-month.
16 months. Osteoid mineralized. Capital femoral epiphysis. So it cannot be skiffy, right? No, probably not.
Usually skiff is not present in this age, isn't it?
At this age, yeah, but she still, it says that she was C-section because of breech. Oh, no, no, she's not fat. Okay, a most avulsion of muscle origin. I don't know what that means. Um,
Is there any possibility of DDH to happen, developmental dysplasia of the hip?
yeah, probably. That's the only thing that's at that age.
Yes,
Um,
and it fits with the like limb length discrepancy, like
yeah.
shorter,
So, what was the cause of developmental dysplasia?
poorly developed acetabulum,
Oh,
where the head
okay. That's fine.
fits. Other thing does not match.
Okay.
Okay, let's see.
Oh, sorry. Okay,
I
this
am
one now.
excluding too much.
You're excluding too much. Okay. Fully develop, you're right. Developmental dysplasia of the hip occurs
I
as
am trying to like get. I'm trying to mimic your idea of answering question because that was a good. Like
yeah, yeah. But
excluding
if
a method is good.
yeah, if you don't
Even
have an idea,
even if
yeah.
even if I try to exclude, but there is an a habit. since lo- uh, last decades that what is the diagnosis? Okay, I can't get it out still now. Okay,
Oh my God.
let's
Result of
start.
abnormal or poorly developed acetabulum in infants. Risk factors include female sex, breast presentation during development, family history of the condition. In infants, there may be an associated limb length discrepancy and inability to abduct the limb. In infants, the Barlow and Ortolani maneuver may be used to test for hip instability and help diagnose developmental dysplasia of the hip. Additional testing include ultrasound may be useful to diagnose infants younger than 4 months. If left untreated, developmental this may result in functional disability, pain, and early osteoarthritis. The most common treatment for infants with this condition is abduction splint, most commonly the pelvic harness. Okay.
Okay,
Yeah.
next.
Mhm.
If you start reading all the options, then whole night will pass. Okay. A 40, a 16-year-old girl is brought to the office by her mother for a health maintenance examination. She has no history of serious illness and takes no medication. Immunizations are up to date. Means are irregular 28 to 35 days interval. Her last menstrual period was 3 weeks ago. She does not smoke cigarettes, drink alcohol, or use illicit drugs. She has been sexually active with one male partner for a year. They do not use condom. Her mother was diagnosed with breast cancer at the age of 40 years. The patient is 5 feet 4 inch tall, weight is 65 kg, BMI is 25 kg per meter square. Vital signs are within normal limits. Breast examination shows no masses or discharges. External genitalia appear normal. There is no vaginal discharge. Breast and pubic hair development are sexual maturity rating is stage 5. Which of the following is the most appropriate screening to administer at this time?
Ready?
Yes.
So it is not for chlamydia and Neisseria. For this healthy adolescent patient, preventive measures will primarily address the sexual health. USPF, whatever, recommends screening all sexually active women under 25 for chlamydia and Neisseria. Chlamydia, common STI infection that cause various infections, cervicitis, PID, epididymitis, or arthritis. However, in many cases, asymptomatic, and thus screening patient is important for finding and treating active infections before long-term sequelae. Yeah, and it's not PAP recommended every 2 years for women 21 to 65. Okay, next.
Okay, next. PAP is for one for how many? The age
21 65.
21 to 6. Okay. A 17-year-old girl is 17-year-old girl comes to the office because she has had a burning sensation at the beginning of urination for the last 24 hours. She has no history of similar symptoms. Examination shows no abnormal urinalysis shows marked pus but no bacteria. Which of the following is the most appropriate next step? Like asymptomatic bacteria, isn't it?
Mm-hmm.
Pass in the urine, but no bacteria.
Ready?
Okay,
Okay, so it is testing for STI. The destination should offer Testing for STI at this time. STI, chlamydia, gonorrhea, syphilis are a major public health concern as they often are asymptomatic and can cause significant complications if left untreated. The lesson that are risk demographic, especially as stigma regarding sexual activity and concerns about confidentiality, may make individuals uncomfortable in disclosing any exposure and concerning regarding STI. Urinary symptoms are common presenting complaint for STI, and UTIs often occur concurrently with the STI. Patients presenting with clinical findings of infection, such as dysuria, pyuria, in this case, should be evaluated for both UTI and STIs. Yeah.
Okay,
Next.
last. A 6-month-old boy is brought to the office for a well child examination. He is exclusively fed cow milk based formula. His mother reports that he takes a bottle vigorously, but he frequently spits up after eating. What is your diagnosis? I think
Okay,
that we got it, isn't it?
pylori acidosis, yes.
Is there any possibility of anything to happen?
No, no diarrhea, no tummy pain, no.
Okay, let's
Okay.
see.
Oh, I knew that. You should have.
But
Yeah,
if
yeah.
we read the whole thing, we are biased with pyloric stenosis.
Oh,
Okay,
Aga.
let's read the question again. What we have missed? GRD with uh, okay. 6 months old boy is brought to the office well child. He exclusively fed cow milk based formula. His mother reports that he takes his bottle vigorously, but he frequently spits up after eating. He has not had diarrhea, fever, development appropriate to age. He dropped from 50th percentile to 35th percentile for weight since his last visit 2 months ago. So 2 months ago he visited to the physician. Length and head circumference remain 50%. The examination shows subcutaneous, but nothing is written regarding GRD. Okay, let's discuss.
GERD, extremely common in infants. This is the result of diminished closing pressure of the lower esophageal sphincter, permitting acid contents of the stomach to go into the esophagus. Reflux events may occur up to 30 times per day. Some of these episodes result in contents entering the oral cavity and decrease through the first year of life. Infants who demonstrate good weight are feeding well and are not irritable are managed conservatively. Modifications may improve symptoms, including having infants avoid secondhand smoke exposure, smaller or more frequent meals, and keeping infants upright after feeding when possible. Infants who experience reflux and poor weight gain should undergo further evaluation for caloric count, ultrasound to rule out pylori stenosis, and have their diets adjusted to thick feeds or breast milk. In patients with refractory case, a trial of PPI may be warranted, and it's not pyloric stenosis caused by hypertrophic of pyloric sphincter resulting in gastric diarrhea, which typically first 3 to 6 weeks of life. It is characterized by repeated vomiting after feeds, leading to dehydration and hypochondria. Okay, the key is the timeline.
Yes,
He 6 months.
pyloric stenosis is 3 to 6 weeks.
So the first 2 months. Yeah. Okay.
We
I,
actually skip the timeline,
yeah. I didn't even know there was a timeline for that. So,
but
like,
this one is needed actually
yeah.
because we are very biased with pyloric stenosis. Even if in the